You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about intramural hematoma of the aorta, aortic plaque, penetrating aortic ulcer, infectious aortitis, and aortic atheroemboli. Let's start with intramural hematoma of the aorta. Intramural hematoma, or IMH, arises from spontaneous bleeding from ruptured vasovasorum into the aortic wall, the medial layer, not the intimal layer, or less frequently as the evolution of a penetrating atherosclerotic ulcer. 33% of intramural hematoma progresses to classic aortic dissection, so it's important to treat this very seriously. Instead of an intimal layer dissection, intramural hematoma causes dissection in the outer media and may extend into the adventitia. The presenting symptoms of ruptured aortic intramural hematoma are indistinguishable from that of classic aortic dissection. Intramural hematoma is localized to the ascending aorta in 30% of cases, aortic arch in 10%, and descending aorta in 60% of cases. Intramural hematoma is responsible for 15% of acute aortic syndromes. Non-contrast CT of intramural hematoma will show a crescentic high attenuation area along the aortic wall without an intimal tear. Contrast CT will show failure of the intramural hematoma to enhance, unlike a classic aortic dissection. TEE of the intramural hematoma will show a crescentic or circumferential aortic wall thickening, an eccentric aortic lumen, and echolucency within the aortic wall with no intimal flap. MRI of intramural hematoma will show a crescent-shaped area of high intensity along the aortic wall. Aortography has low sensitivity for diagnosing intramural hematoma because there is no communication between the intramural hematoma and the main lumen of the aorta. Unlike aortic dissection, which is more common in men, there is an equal prevalence of males and females with IMH. Management. Aortic intramural hematoma requires emergent surgical repair due to the risk of aortic rupture, which is quite high, and there is a 40% mortality if no surgery is performed. What is the definition of IMH with complicated features? That is when IMH has malperfusion, periaortic hematoma, pericardial effusion with cardiac tamponade, persistent refractory or recurrent pain, or rupture. So let's listen to what does the 2022 AHA-ACC guideline for the diagnosis and management of aortic disease say about type A intramural hematoma, which is the ascending type. The classification is the same as for aortic dissection, type A and type B IMH, for ascending and descending aorta. So for type A, they say in patients with complicated acute type A or type B aortic IMH, urgent repair is recommended. That's a class 1 recommendation. In patients with uncomplicated acute type A IMH, prompt open surgical repair is recommended. Class 1. So type A is treated very seriously. In selected patients with uncomplicated acute type A IMH who are at increased operative risk and do not have high-risk imaging features, an initial or expectant approach of medical management may be considered. Class 2B. What about type B IMH? As I mentioned, in patients with complicated acute type A or type B aortic IMH, urgent repair is recommended, class 1. In patients with uncomplicated acute type B IMH, medical therapy as the initial management strategy is recommended. That's a class 1 recommendation. In patients with type B IMH who require repair of the distal aortic arch or descending thoracic aorta, zones 2 to 5, and have favorable anatomy, endovascular repair, that's the percutaneous repair, is reasonable when performed by surgeons with endovascular expertise, class 2A. In patients with type B IMH who require repair of the distal aortic arch or descending thoracic aorta, zones 2 to 5, and have unfavorable anatomy for endovascular repair, then open surgical repair is reasonable, class 2A. In patients with uncomplicated type B IMH and high-risk imaging features, then intervention may be reasonable, class 2B. Now let's move on to aortic plaque and penetrating aortic ulcer. Aortic plaques are graded as grade 1 to grade 5. Grade 1 is normal, 2 is mild, 3 is moderate, 4 is severe, and 5 is complex. What exactly are these defined as? Grade 1 aortic plaque, which is normal, is an intimal thickness of the aorta less than 2 millimeters. That's normal. Grade 2 aortic plaque, which is mild, is when you have mild, focal or diffuse intimal thickening of 2 to 3 millimeters. Grade 3, which is moderate, is when you have an atheroma of more than 3 to 5 millimeters, with no mobile or ulcerated components. Grade 4, which is severe, is when you have an atheroma of more than 5 millimeters, with no mobile or ulcerated components. Grade 5, which is complex, is either grade 2, 3, or 4 atheroma plus a mobile or ulcerated component. In other words, the cutoff between normal, mild, moderate, and severe atheromas are 2, 3, and 5 millimeters. And then if you have a mobile or ulcerated component, either 2, 3, or 4 grade atheroma can be upgraded to grade 5, which is complex. Penetrating atherosclerotic ulcer or penetrating aortic ulcer, PAU, occurs when an atherosclerotic plaque ulcerates and burrows through the internal elastic lamina into the media, leading to a variable amount of intramural hematoma which may extend proximally or distally. Penetrating atherosclerotic ulcer may precipitate intramural hemorrhage, pseudoaneurysm, aneurysmal dilations, or aortic rupture. What do the guidelines say for penetrating aortic ulcer? According to the 2022 AHA-ACC guideline for the diagnosis and management of aortic disease, if PAU occurs with rupture, IMH, or both, in patients with PAU of the aorta with rupture, urgent repair is recommended. That's a class 1 recommendation. In patients with PAU of the ascending aorta with associated intramural hematoma, urgent repair is recommended, class 1. In patients with PAU of the aortic arch or descending thoracic aorta with associated intramural hematoma, urgent repair is reasonable. That's a class 2A recommendation. In patients with PAU of the abdominal aorta and associated IMH, urgent repair may be considered, class 2B. So the indication for urgent repair of PAU is strongest at the ascending aorta, and it gets weaker for the arch and weaker for the abdominal aorta. In patients with atherosclerotic thoracic abdominal aorta aneurysm and concomitant aortic atheroma or PAU penetrating aortic ulcer, the use of low-dose aspirin is reasonable unless contraindicated, class 2A. Now, what if PAU occurs in isolation without rupture or IMH? Asymptomatic isolated PAUs are increasingly being diagnosed incidentally because of the increasing use of CTA. In patients with isolated PAU who are symptomatic and have persistent pain that is clinically correlated with their radiologic findings, repair is recommended, class 1. In patients with isolated PAU who are asymptomatic but have high-risk imaging features, elective repair may be considered, class 2B. What are the high-risk imaging features of penetrating aortic ulcer? Maximum PAU diameter of at least 13 to 20 millimeters, maximum PAU depth of at least 10 millimeters, significant growth of PAU diameter or depth, PAU associated with a saccular aneurysm, or PAU with an increasing pleural effusion. In terms of the type of repair, in patients who require a repair of a penetrating aortic ulcer in the ascending aorta or proximal aortic arch, zones 0 to 1, open surgical repair is recommended, class 1. In patients who require repair of a penetrating aortic ulcer in the distal aortic arch, zones 2 to 3, descending aorta, thoracic aorta, or abdominal aorta, either open surgical repair or endovascular repair is reasonable based on anatomy and medical comorbidities, class 2A. Now let's move on to infectious aortitis. Sometimes it's called aortitis. Infectious aortitis refers to infection involving the aorta, replacing the older term mycotic aneurysm, which specifically refers to fungal infections. Aortic infections typically due to spread from nearby tissues or through the bloodstream, either from septic emboli or direct infection of the aortic wall, often through a pre-existing aneurysm or atherosclerotic plaque. The most common pathogens associated with aortic infections include Staphylococcus aureus, pneumococcus, E. coli, and salmonella. though historically more common syphilitic aortitis from Treponema pallidum is now rare. Fungal infections, typically Candida or Aspergillus, and tuberculous aortitis generally affects patients with compromised immune systems. Medical therapy is challenging because the causative organism is not always identified, but a prolonged course of antibiotics is often warranted. Infectious aortitis has a high mortality rate because it can be complicated by sepsis, aneurysm formation, pseudoaneurysm formation, aortic dissection, aortic rupture, and formation of aortoenteric fistula. Now let's talk about its management. Open surgical repair is used for most cases of infectious aortitis, especially in patients with aortic rupture, fistula formation, hemodynamic instability, or failed medical management. Endovascular repair, which is TEVAR or EVAR, may be used in those unfit for open surgery. Endovascular repair is often a bridge to definitive surgery as infection can persist around the graft. Endovascular graft infection rates are higher than in open surgery. What do the 2022 aortic disease guidelines say about infectious aortitis? In patients with infectious aortitis and associated aneurysms or dissection of the thoracic or abdominal aorta, open surgical repair is recommended. That's a Class 1 recommendation. In select patients, treatment with endovascular repair may be considered 2B. In patients with infectious aortitis complicated by rupture, either open or endovascular repair is reasonable based on the patient's status at presentation and institutional expertise, Class 2A. In patients with infectious aortitis, intravenous antimicrobial therapy of at least 6 weeks duration may be considered, with lifelong suppressive therapy in select cases not amenable to interventional repair or who have a recurrent infection, Class 2B. Now, let's talk about aortic atheroemboli. That's our last topic for this episode. Atheroemboli can be produced by mechanical manipulation of an atherosclerotic aorta via catheters or during surgery, especially resection of abdominal aortic aneurysm. The kidneys are common targets for such embolism, resulting in acute renal failure with a stepwise decline in function, sometimes progressing to ESKD. The atheroemboli can lodge in terminal arteries of the kidney, causing localized glomerular ischemia, or may compromise the large arteries and cause loss of entire renal function. Urinalysis sometimes shows lipid droplets, but usually is unremarkable, with only mild proteinuria and a bland sediment. There may be peripheral eosinophilia and low serum complement levels. Atheroemboli to the pancreas can also cause pancreatitis. Eosinophilia and eosinophiliuria are seen in up to 80% of patients with cholesterol embolization due to the inflammatory response to the cholesterol emboli. In 50% of patients, there will be livedo reticularis, which is net-like purple discoloration in the lower extremities due to atheroemboli. Sometimes there may be purple toes, purpura, and even gangrene. If the atheroemboli are from the proximal aorta, they may cause atheromas in the retinal arteries. Large renal atheroemboli may be amenable to surgical or catheter removal, but the management of atheroemboli is usually supportive, including hemodialysis. Use of anticoagulants to prevent further episodes of embolization remains controversial. That's all for intramural hematoma of the aorta, aortic plaque, penetrating aortic ulcer, infectious aortitis, and aortic atheroemboli.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.